This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Fellows Conference. As you can see, our speaker this morning is Mariem Sawan. Mariem is a third-year fellow in the basic science track. She was born and raised in England, educated in the Middle East, came to the United States for residency to the University of Maryland, where she worked some with our former faculty member, Alok Finn, came here as a member of our basic science research track, worked in Dr. Taylor's lab, and will be staying on as an interventional fellow with us in a couple years. As you can see today, she's going to talk to us about coronary artery calcification. Mariem.
Thanks, Dr. Okay. Thank you, Dr. Williams. Good morning, everyone. As mentioned, my talk is about coronary artery calcification, and I have no relevant disclosures. Here are my objectives. First, to understand the pathobiology of vascular calcification, and then evaluate the use of coronary artery calcium score to guide a personalized risk-based approach, and then identify the impact of coronary calcification on percutaneous coronary intervention. Lastly, explore the contemporary percutaneous approaches to heavily calcified coronary lesions. I'll start off with a case. So my patient here is a 77-year-old female with past medical history of hypertension, dyslipidemia, and diabetes, and coronary artery disease, status post-PCI, who presented with worsening exertional angina despite medical therapy. Her echo showed an EF of 65, which is normal, but she did have a positive nuclear stress test, and her angina was not improving on medical therapy. And so here is her angiogram. Her left system, it was previously intervened upon. She has a stent in LAD and also the obtuse marginal. Her right system shows a severely calcified proximid RCA lesion. They were unable to pass a balloon through the lesion to dilate it. So the interventionist used a more contemporary device to help open the vessel, which I'll talk about more later in this talk. We've known about the presence of vascular calcification for decades. It's afflicted humans for at least 5 millennia. On the left, you see a cross CT scan of ice mummy that was found by a German couple that were hiking in Austria. The ice mummy, which the scientists believe is more than 5,000 years ago, 5,000 years old, showed evidence of vascular calcification in his aorta, which is seen on this transverse CT section. The aorta in the image is actually collapsed. And before the invention of light microscopy, the famous Italian anatomist described back in the 1500s what he thought was degeneration of the arteries into bone on autopsy. And in the 1800s, the German scientist Virchow described what he believed was ossification of the arteries in a lecture series that he delivered in the Institute of Pathology in Berlin, Germany. His use of the term ossification is very interesting. Unfortunately, for decades, vascular calcification was still thought to be an entirely degenerative process, largely related to aging and results in calcium accumulation. This was until pathologists saw evidence of osteogenic fingerprints in human vascular tissue. The left here shows a cross-section of a myxomatous mitral valve in a middle-aged man, and it shows an area with a huge amount of chondrocytes. And the image here on in the middle is a cross-section of a middle-aged man who suffered from a massive MI. He had a out-of-hospital arrest, was resuscitated, brought to the nearest ED, and his EKG showed ST elevations, and a quick echo showed that his entire anterior wall was down. He was taken to the cath lab and undergone PCI, but unfortunately, he suffered from severe anoxic brain injury and he didn't make it. So this is his autopsy of the left anterior descending artery. And you can see that the artery has a huge amount of atheroma and near complete occlusion of the lumen. And then there's a segment within the artery where there's active osteogenesis occurring. And a closer look, you could see that it actually looks exactly as you would see in trabecular bone cross sections. And there is a lot of fatty bone marrow. The images on the bottom are from a femoral artery that shows that was severely calcified. You see the segment here, the darker staining is all calcification. And then closer look up, you can see that there was a lot of amount of dense extracellular matrix in the lumen. There's evidence of what appears to be a bone marrow. And the arrows here are pointing to a multinucleated osteoclast. On a different segment, there's more active osteogenesis occurring with type 1 collagen deposition and multiple osteoclast and osteoblast cells. So it's worth mentioning that actually vascular calcification or osteogenesis of the vasculature is one of the more common, or one of the most common metaplasias in the human body. But you don't always see evidence of osteogenesis in vascular calcification. But the finding of osteogenic fingerprints in these human tissue did spike a lot of interest. And the question is whether vascular calcification is actually a passive process, or is it also an actively regulated process? And so this is an in vitro study. And what they did was they got vascular smooth muscle cells from human arteries that were undergoing some other type of surgery. And they cultured them in two different media. There's a control group and a high phosphate group. The vascular smooth muscle cells in the control group were in media that we usually use that is as comparable to a physiological state as possible that we can do in the lab. And then the high phosphate media was just high in phosphate, something comparable to what you would see in patients that have chronic kidney disease. And they left them incubated in the same setting for 7 days. And then they stained them with a red Elizarian stain, which is usually used to identify the presence of bone because it stains red in the presence of calcium, and bone is heavily calcified. And as you can see here, grossly, the control group media didn't turn red, but the high phosphate group did, indicating the presence of calcium. And under light microscopy, you see the control group, the smooth muscle cells look normal. They're long, spindle-shaped, smooth muscle cells. But in the high phosphate group, they actually transdifferentiated into osteoblasts, and they deposited a huge amount of calcium. They then measured the levels of the intracellular calcium, and they compared them between the two groups. And as you can see, the high phosphate group had a significantly larger amount of calcium than the control group. And then they also ran qPCR on these smooth muscle cells to see if they also express same markers that you'd find during bone formation, and they did. So, and we'll talk about these different markers in a little while, but the high phosphate group had a significantly higher level of these markers compared to the control group. So this study and many, many more went. Okay. This study and many more prove that vascular smooth muscle cells are capable of transdifferentiation and osteogenesis. And more importantly, that vascular calcification appears to be an actively regulated disease that can't be exclusively characterized as senile or degenerative. So there are a lot of histoanatomic types of vascular calcification, but here are the more common ones. Atherosclerotic intimal calcification, there's medial artery calcification, calcific aortic valve disease, calcific uremic arteriopathy, which is also known as calciphylaxis, and vascular calcification of ESRD. In my talk, I'm going to be focusing more on the coronary artery calcification types, which is usually the intimal calcification and medial calcification. There's a newer entity that we're not sure where it falls into, which is the calcified nodule. So the pathobiology of intimal calcification. So intimal calcification first starts off with atherosclerosis. So atherosclerosis occurs before intimal calcification. And we know that atherosclerosis is an inflammatory process that starts with damage of the endothelium. Then monocytes enter the artery and differentiate into macrophages, which proliferate locally. They ingest oxidized lipids, and then they slowly start to turn into large foamy macrophages. And then they eventually die, and which further propagates the inflammatory process. In addition, the smooth muscle cells start to proliferate, and they migrate from the vessel wall in response to cytokines that is secreted by damaged endothelium cells and by the dying cells. And they help, and these smooth muscle cells are thought to help form the fibrous cap. Then the calcification starts to occur, and intimal calcification really resembles endochondrial bone formation. And although the initiation of the calcification does not require participation by specific cells, but the progression of the lesion is thought to be likely driven by chondrocyte-like cells and associated with expression of inflammatory factors like cytokines. And there are 4 mechanisms that have been proposed for the initiation of calcification, intimal calcification. The first is the death of inflammatory cells in atheroma-releasing apoptotic bodies and necrotic debris that serve as the nucleating sites for calcium phosphate crystal formation. The second is matrix vesicles released locally that are circulating nucleation complexes that serve as a site for calcium complex crystallization. There's reduced local expression of mineralization inhibitors, and then there's also induction of bone formation resulting from differentiation of pericytes and or vascular smooth muscle cells. Now, there is a large body of work looking into where these vascular smooth muscle cells are coming from, whether they're coming from the vessel wall or if they're migrating from the bone marrow. And it's thought to be, in the case of intimal calcification, more than half of them, or 80% of them, actually migrate from the bone marrow, and the rest of the vascular smooth muscle cells that migrate and induce the calcification are from the vessel wall itself. So in essence, intimal calcification is a highly, it's an inflammatory process, and really induced by local inflammation. When it comes to pathobiology of the medial calcification, the mechanism is different, and it's largely driven by the action of osteoblast-like cells. It can result in a consequence of disordered calcium phosphate regulation in the blood, leading to the activation of bone-forming programs like bone morphogenetic protein 2, which is characteristic of intramembranous bone formation. And it belongs to the transforming growth factor beta superfamily of proteins, and it induces the cells to undergo osteogenic differentiation, leading to the production of bone-like matrix. And in diabetes, diabetes is also, medial calcification is also very common in diabetics with or without dyslipidemia. And what happens is the hyperglycemia upregulates the adventitial TNF production by monocytes and macrophages, which in turn induces procalcific MSX2 activity and paracrine WNT signaling cascade that promotes calcification and fibrosis. There are also numerous regulators of calcification, such as osteopontin and matrix gala protein, that are also involved in medial calcification. Unlike calcification in the intima, most of the vascular smooth muscle cells that transdifferentiate are thought to actually originate from the wall itself. When it comes to calcific nodule or eruptive calcific nodule, I'm not sure where it really falls into. It might be just a different type of morphology, or we haven't really looked into if there's a difference in the mechanism behind the formation of a calcified nodule. But in this study, it was largely a histology study. They had a large registry of patients that died, and they had calcified nodules, and they looked at 26 consecutive lesions. And they found that there was a high prevalence of diabetes and CKD among these patients. And it was equally distributed between men and women, so there was no gender difference between the two. It was predominantly found in the proximal to mid RCA. And they found that there was circumferential severe calcification in all of the subjects. But if you take a close look, this is one of the calcified nodules. B and C are the areas that are proximal to the nodule. D and E are the nodule itself, and then distally to the nodule. The reason they think that calcified nodules, especially in the right coronary artery, are more at a higher risk of eruption and leading to acute coronary syndrome is that it usually occurs in this hinge point of the artery. And so during systole and diastole, this area of the coronary of the right artery kind of is more prone to stretch. And they found that the calcified nodule itself, although it's more high in necrotic tissue, and there was less dense fibrous tissue, and a lower amount of collagen. But the regions just before it, the proximal and distal, were actually high. They had sheets of calcium, and also more collagen matrix with densely that are more dense. And I think that's the mechanism behind why these calcified nodules erupt. The main characteristics and clinical effects of medial and intimal calcification. So grossly speaking, so the medial artery calcification occurs in the medial vessel wall, and it's usually more concentric, and it causes stiffening of the vessel. It rarely, if ever, causes stenosis or lumen narrowing. But with intimal calcification, it's more eccentric, and it's in the intima, as the name implies, and it does lead to lumen narrowing. The natural progression of, so in medial calcification, you usually find that they calcify very early, but with intimal calcification, it occurs later on. And what is believed is that medial calcification or arteriosclerosis causes stiffening of the vessel, which then increases systolic and pulse pressure, and that could alter coronary perfusion and lead to left ventricular hypertrophy. When it comes to intimal calcification, it starts off with atherosclerosis, and these atherosclerosis then cause heavily calcified plaques that do cause lumen narrowing and stenosis of the vessel. And if it's unstable plaque, it can lead to infarction and ischemia. The risk factors for coronary calcification, so you'd see that age is a factor that plays a role in both. Diabetes is very common in both medial and intimal calcification. Dyslipidemia is thought to it's actually not a risk factor for medial calcification, because a lot of the medial calcification that we see in patients with CKD especially, they have a lower lipid profile and heavily calcified media, whereas dyslipidemia is definitely a risk factor for intimal calcification. Intimal calcification, hypertension is a risk factor, but with medial calcification, it isn't. It's thought that the medial lesion actually worsens the blood pressure. And when it comes to kidney disease, so renal dysfunction, it is a risk factor for medial calcification. hyperphosphatemia is a risk factor for both, and the duration of dialysis is a risk factor for medial calcification. So in part 2 of my talk, I'll be evaluating the use of coronary artery calcium score to guide a personalized risk-based approach. So we use cardiac CT for calcium scoring. It's a great tool for risk stratification and prevention. It's very easy. It takes 10 minutes and it only is 1 millisievert of radiation, and we can see the calcium on an unenhanced cardiac gated CT. So it's very user-friendly. The use of coronary calcium as a surrogate marker for coronary atherosclerosis burden was started actually by this study by Ramberger et al., published in the 1990s, where he looked at 38 coronary arteries from 13 autopsy hearts, and he dissected them and scanned them by CT, and then compared the sum of the atherosclerotic plaque that he saw by histology to the sum of calcium seen on CT, and found that the coronary calcium highly correlates with coronary plaque area. And so from there, a lot of research has been done to look into how strong of a risk predictor is coronary calcium. In the study, close to 7,000 subjects from 4 racial or ethnic groups were scanned. They were all between the age of 45 to 84 and had no clinical cardiovascular disease at the time of enrollment. And they were followed for a maximum of 5.3 years. And as you can see, calcium score was a strong predictor of coronary artery disease. And coronary calcium is found to be superior to other risk markers as predicting coronary heart disease. In this study from MESA, which stands for Multi-Ethnic Study of Atherosclerosis, it's a large prospective multiracial and ethnic study, and they enrolled 1,300 subjects who were at intermediate risk for coronary artery disease and had complete data for 6 commonly used risk markers, which were carotid intima, to media thickness, brachial flow mediated dilation, C-reactive protein, family history, and ABIs. And they compared them and found that coronary calcium provided a superior discrimination compared with other risk markers. And none of these subjects had diabetes. And when they looked at the event rate for coronary heart disease stratified by a coronary calcium score for subjects with and without statin indication, according to both the European and the old American ACC cholesterol guidelines, they found that coronary event rates increased with calcium score, but not relevantly with statin indication by either guidelines. And the study included over 3,000 subjects, and it indicates that coronary calcium score can actually help guide risk-based selection for patients who are appropriate for preventive therapies. So who gets a calcium score? If you look at the 2018 guidelines for cholesterol, the cholesterol guidelines, you'd see that patients that are at an intermediate risk are the ones that are encouraged to undergo a calcium score. So if we start from the top, patients from the age of 0 to 18, you would encourage them to have more lifestyle to prevent or reduce ASCVD risk. And patients from the age of 20 to 39, you estimate the lifetime risk to encourage lifestyle to reduce ASCVD risk score, and you would consider statin if they do have a family history of premature ASCVD and an LDL of more than 160. But when it comes to patients between the ages of 40 and 70 without diabetes, you would calculate their risk based on the ASCVD risk calculator. And if you'd look at the risk calculator, it incorporates race, sex, age, total cholesterol, HDL, and the systolic blood pressure, and whether or not they're on hypertensive medications and diabetes and smoking, and then it spits out a 10-year risk. And you'd use that to see whether your patient is at a low, borderline, intermediate, or high risk. It's worth noticing that here in this calculator, it just asks whether or not the patient has diabetes. Regardless of how long the patient had diabetes for, if it's controlled or not controlled, if they're on insulin or not, if it's type 1 or type 2. And so if the patient had no risk factors and just had diabetes, they would most likely fall in a low risk or intermediate risk. But we do know that diabetic patients should be on moderate statins. But whether or not this patient who had presumably type 1 diabetes for 10 years might benefit from a high intensity statin is unknown if we use this scheme. And so when it comes to younger adults, there hasn't been much data on the performance of different risk markers to help predict cardiovascular disease risk in this group. And in this study, they measured calcium scores of more than 13,000 subjects that were between the ages of 30 to 49 years old without known cardiovascular disease. And they followed them for a mean of 11 years and found that coronary calcium score significantly improved the prognostic accuracy of risk factors for MACE, MI, and all-cause mortality. But the prevalence to begin with of coronary calcium in this age group is pretty low. And in the elderly population and in patients with CKD, current cardiovascular risk scores are not well validated. But in these two studies, they used calcium score, and it did help predict cardiovascular outcomes. As you can see here on the left, they took 2,400 asymptomatic patients with a mean age of 79, and they followed them for 10 years, and they found that higher calcium scores was associated with an increased cardiovascular risk and all-cause mortality. And then the right, these are patients with CKD, mild to moderate CKD, and they found that there was a graded association between the calcium score and their GFR. And the hazard ratio for cardiovascular events was higher in CKD patients with higher calcium scores. And so in another study trying to model the recommended age for initiating coronary artery calcium among at-risk young adults, they took more than 22,000 coronary calcium consortium participants that were between the ages of 30 and 50, and they had, some of them had diabetes, half of them had diabetes and the other half didn't. And they compared them with individuals without risk factors. And they found that diabetes and the patients that had diabetes developed coronary calcium almost 6.5 years earlier on average than the ones that didn't. And so from this study, they concluded that, and they recommend that the optimal age for potential first scan is earlier for men than with diabetes than women, because also they found that men had a higher, were at a younger age when their calcium scores increased. So the recommendation from this study is that men with diabetes should receive a calcium score between the ages of, you consider it between the ages of 35 to 38. Women with diabetes between the ages of 49 to 52. Men without diabetes between the ages of 41 to 44, and women without diabetes between the ages of 56 to 60. So how do you calculate the calcium score? Before I move forward, I think this is important to understand the limitations of the current risk score that we use. So what you do is you do a CT scan, and then you go to the z-axis, and you circle where the calcium is. And what happens is the computer gives you a density of the calcium score in Houseman units, and then you see what that correlates to in the density. So if the Houseman units is between 130 to 199, that's score 1, and between 200 to 299, that's 2. Between 300 and 399, that's 3, and more than 400 Houseman units, that's a 4. And then it also gives you the area size. So you, and you're, with those two numbers, you're able to calculate what that score is. And then the Agatston lesion score is actually the sum of all of the lesions that you would see on the CT scan. And just as a reminder, the Housefeld scale is actually, the more dense the tissue is, the higher it is. And so if you can see here, bone and cortical bone have higher densities than the other tissue. And the grading of coronary artery disease based on total calcium score is, if it's 0, there's no identifiable disease. And if it's 1 to 99, there's mild disease. If it's 100 to 399, it's moderate. And if more than 400, that's severe disease. And so with this, we would classify patients accordingly to the grade of coronary calcium. But if you look here, these two patients have the exact same score of 200. But are they really the same? Each of them have the same calcium, but the patient in the left has all of his calcification in the prox-LAD, and the patient on the right has coronary calcification that's scattered throughout his coronary system. They both have the same score, but as mentioned, and they have a different area of calcium, they have a different density of calcium, different number of vessels that are involved, and different pattern of calcium. And so that led to a series of research to see whether or not there is if the distribution is an independent predictor of incident of major coronary heart disease events. And in this study, they showed results from the Framingham Heart Study, a little over 1,200 subjects. Their mean age was 56, plus or minus 10 years, and 63 were men. And they all had a score of more than 0 and had no prior history of coronary heart disease. And they found that the number of coronary arteries with calcification and the presence of the calcification in the proximal dominant artery was associated with major coronary artery disease events. They also found that there was association in a different paper. There's an association between left main calcification and cardiovascular specific and total mortality. And this mortality and this data is from a multi-centered population-based retrospective cohort. And the patients were all age of 18 and above without known coronary artery disease. And they were all obviously asymptomatic, and they were referred for a calcium score. And it did show that patients with left main disease were at an increased risk of cardiovascular disease and total mortality. This is a smaller study where close to 1,500 asymptomatic patients were referred by their PCP for evaluation of their coronary calcium. And all of them had at least one risk factor, but no prior history of coronary artery disease. And they did show, this is not shown here, that patients with greater number of calcified lesions were generally older, less likely to be female. And what's interesting in this study is that they looked at the patients that only had one calcified lesion. And they looked at their cumulative survival, and they found that the patients that had one lesion of more than 1,000 had a greater mortality than those with lesser extent of calcium. And they also found that when they did an annualized risk adjusted mortality by score in the LAD and left main, they found that an annual mortality was increased with the increase of left main coronary artery calcium scores. And actually there were 4 patients that had a coronary calcium score of more than 1,000, and they had only one lesion, and this lesion was in the left main, and they died during follow-up. They also found that the annual mortality was higher with the increase of calcium score if it were in the left anterior descending, but the mortality wasn't higher in the left circ or RCA territory. So Moving on to very high calcium scores and what to do with it. So in this study, they had more than 66 asymptomatic adults that they looked at, and it's a large retrospective multi-center clinical cohort study. And they found that there was close to 3,000 patients with a calcium score of more than 1,000, and most of them had 4-vessel disease and had a greater calcification area, and a higher mean density and more extracoronary calcium than those with a calcium score of 400 to 999. They also found that they had a 5-fold increase of CBD, a 6-fold increase in heart failure, and 1.5 increase in cancer, fold increase in cancer, and 2.9 fold increase in all-cause mortality. And as you can see here, they also found that there was, on their graphic analysis with patients that had a calcium score of more than 1,000, showed a continued logarithmic increase in risk with no clear evidence of risk plateau. And so this study really shows that a calcium score of more than 1,000 represents a unique and a very high risk phenotype with mortality outcomes that are comparable to high risk secondary prevention patients. And so the thought here is that maybe these patients with a extremely high calcium score should be treated the same as patients with secondary prevention. On the other end of the spectrum, when they compared negative risk markers in MESA study, which is the multi-ethnic study that I mentioned earlier, they found that a calcium score of 0 was the strongest negative risk factor for the development of ASCVD, and they compared it with a lot of different markers. But a calcium score of 0 does not mean 0, right? So if you can see here, these patients had a calcium score of 0, and there's still some risk. So the concern is whether or not how accurately does coronary calcium detect low intensity or low attenuation non-calcified plaques, which are known to be more dangerous. So in this study, you can see that cardiovascular risk stratified by plaque type. And this is not a CT, this is a CCTA, which should not be used for risk stratification of primary prevention. It's only used in patients that have no history of coronary artery disease and complaining of chest pain. But in any case, just to demonstrate that they looked at the different types of plaque and to see the event rate, and patients that had non-calcified plaque had a higher event rate. And so in this study, what they did was they compared the low attenuation non-calcified plaque, which is known to have a higher risk of mortality in ACS, with the calcium score, and they actually found that it is very comparable. Before moving forward, I wanted to just briefly mention something that I would have never known if it weren't for my sister, who's a pathologist, a radiologist, who told me that actually in 2016, in their 2016 guidelines, even in CTs that are not gated, it's a class 1 indication for them to evaluate and report the amount of calcium in the CT scan. And they also should estimate, and it should be estimated as non-mild, moderate, or severe. And it actually shows that imagers, especially the ones that are more versed in reading CTs, can actually very accurately determine the amount of calcification. So this can be used if a patient of yours did undergo CT scan. So for evidence that I just showed you, the National Lipid Association scientific statement on coronary artery calcium scoring, suggesting a different risk score or a risk guide to prevent strategies for ASCVD risk reduction. And in here, you'd see that the majority of the patients did undergo coronary artery calcium screening. And for instance, in patients here that had diabetes and they were between the ages of 40 to 75, they underwent a calcium score. And if their calcium score was more than or equal to 100, they would recommend that these patients should be on a high intensity statin, unlike in our recent guidelines where you would put these patients on a moderate intensity statin without knowing what their calcium score is. So talking about statins, we know that statins significantly reduce risk of MACE in patients with coronary artery calcium. But how does that play into the morphology of the plaque itself? So in this study, they found that actually statins were associated with a slower progression of overall coronary atherosclerosis volume, and it showed an increased plaque calcification and reduction of high-risk plaque features. So it stabilizes the plaque. This study really helps put everything together. So the calcification starts with very small punctate calcification, and these are more at risk for plaque rupture and erosion. And as the calcification increases, it becomes more of sheets and diffuse calcification. If you look at the calcium score, but how does that relate to the calcium score? So the calcium score does go up as the calcium goes up. But the clinical outcomes when the calcium is initially like micro calcification and only punctate, especially if it's on the fibrous cap of the plaque, there's a higher risk of ACS. But as the calcium score increases and the calcification becomes more diffuse and nodular, it can cause more decreased flow and maybe cause typical angina and ischemia leading to heart failure. And so the natural progression of atherosclerotic plaque, as I mentioned just before moving forward, and this really helped put everything into perspective for me because so you start off with a normal vessel. Early in life, even in neonates, you would find fatty streaks, and then it starts with an intimal, there's white blood cells and lipid-rich plaque, and then the calcification starts. So the calcium score and the CT actually detects calcium starting from this space. And then one of the calcium, the plaque, it can scar over, or it can start to become, if there's more micro calcification, it becomes a more vulnerable plaque. If there's a plaque rupture, what happens is, as we know with ACS, there's platelets and fibrin accumulation, and that causes a thrombus, and that's what we see in ACS. But this not always happens. Sometimes what happens is it goes from being a more calcified, vulnerable plaque, and if there's no plaque erosion or rupture, it can stabilize and continue to be, the same size. But sometimes what happens is that with repeated micro rupture of the fibrous plaque, it can lead to layers upon layers of calcification. And when that happens, and it's called negative remodeling, it can obstruct the lumen of the vessel. And so you'd have a very dense and stable plaque, but it is causing limiting the flow of the coronary artery, which would lead to ischemia. Unfortunately, statins help decrease the progression of the plaque, but it does not reverse this. So part 3 of my talk is to identify the impact of coronary calcification on PCI. And so coronary calcium is a predictor of worse prognosis after PCI with drug-eluting stent. And so this is a meta-analysis of 7 trials with little over 6,000 patients. 20% of them had severe calcification. They showed the outcomes at 3 years, and patients with severe calcification had high risk of death, MI, and mortality. When it comes to the impact of calcification, it also impacts the strut and the stent itself, and how it and how it heals. So when you put this is a study done on autopsy specimen of patients that died, and they looked at lesions that are heavily calcified and compared them with stents, and compared them with lesions that didn't have extensive calcium. They found that the lesions that were heavily calcified were less likely to be covered. So normally what we'd want to happen is that you'd have normal, when you put the stent, there would be normal, the epithelium would cover these stents, and that would decrease the risk of restenosis. But when there was heavy calcium, and especially when the struts were in proximity of the calcium itself, they were less likely to be covered. And these arrows are actually pointing at macrophages that are covering the struts itself. And so they looked at the prevalence of malopposed struts was significantly higher in the severely calcified group than non-calcified stents. And then they also found that there was severe medial tear that occurred more frequently in the calcified lesions compared to the non-calcified lesions. And also they found that there was the prevalence of sections with 3 or more consecutive struts in direct contact with surface calcified area per lesion was also significantly higher. And they proposed that this might be a reason why restenosis or stent failure as a whole occurs. When it comes to CTO, they looked at how calcification influences the procedural outcome. So this is a study out of Italy, and they got more than 300 CTO lesions consecutively treated, and they achieved a success rate of 86%. They looked at the predictors of angiographic failure. They found that the vessel diameter, if it was less than 2.5, and the CTO length and severe calcification was a predictor of angiographic failure. But if you see here, the duration, for instance, of the CTO was not significantly different and did not affect procedural outcome. When they looked at this under histology, so actually CTO a lot of times is not a complete occlusion of the vessel, and there is microchannels within the vessel that you'd see on histology. But in any case, the material that causes CTO can be different. And so it could be an organized thrombus, proteoglycan-rich thrombus. It could be a calcified CTO or a non-calcified CTO that's rich in type 1 collagen. So in this study, they took 95 CTO lesions from 82 patients. They looked at the type of material that's occluding the vessel, and they found that patients that had a CTO that was longer than 12 months, there wasn't a significant increase in calcification and calcium in these vessels. But in patients that had CTO with bypass grafts, which we know that is harder to open, there was a significant increase on calcification in these vessels. And so that goes hand in hand in what we see clinically and how difficult opening a CTO with patients with bypass graft. They also found that the cap is more likely to be blunt in these cases. It wasn't significantly different though. So in my last part, I wanted to explore the contemporary percutaneous approaches to heavily calcified coronary lesions. So firstly, right now, there's different imaging options for coronary calcification in the cath lab. So coronary angiography is actually a very poor predictor of detection of coronary calcium. And then you have IVUS, which is intravascular ultrasound. that has a better detection of calcium than by coronary angio alone. And there's also IVUS, intravascular ultrasound radiofrequency, and it provides in vivo assessment of both atherosclerotic plaque composition and morphometry, and may yield insights into the plaque biology. And it has a better quantification of coronary artery calcium than IVUS alone. And lastly, there is OCT, which is optical current tomography, and it uses, so IVUS uses sound waves, but OCT uses infrared light, so it has a significantly greater resolution, but a lower tissue penetration. And the imaging as a whole has been extremely helpful, not only to detect the presence of calcium or coronary calcification, but it also helps size the vessel appropriately and help assess adequate stent expansion, yielding a much better results. We know that Dr. Guenzing back in the 1900s was the first to introduce balloon dilatation to help prep the vessel for for PCI. And since then, there has been an advancement in the type of modalities used in the cath lab to help prep the vessel. I'll talk about briefly. Firstly, there's the cutting balloon, and there are different forms of these cutting balloons. They're usually all non-compliant balloons, and they have microtomes or wires on the balloon to score the plaque. And they're used for only mild and sometimes moderate calcified lesions. Then there is the atherectomy. There's rotation on orbital atherectomy. The rotablator is a front cutting device, and the orbital atherectomy is a circumferential cutting device. The difference here is the rotablator forms a channel, whereas the crown on the orbital atherectomy oscillates in an orbital path. There's also lithotripsy. So lithotripsy has been used for over 30 years for the treatment of kidney stones. We're now using it in intravascularly to help break and crack calcium in the vessel. And so if you see here, the way it works, if you put it, it can minimize, it can crack the calcium, but when you put it against the soft tissue, actually does not cause any harm. And this is a nice demonstration, I'm not sure if you guys can hear it, of how the intravascular lithotripsy causes cracks in the calcium in situ. So there's expanding and collapsing vapor bubble. It creates a short burst of sonic pressure waves. And these sonic pressure waves travel through the vessel with an effective pressure of around 50 atmospheres. And then it actually is thought to help crack not only the intimal calcification, but also medial calcification, unlike the other devices. So going back to our patient, they were unable to pass a balloon. You can see how severely calcified and narrowed that vessel is. But then with the use of a rotablator, they were able to go in a few times, and then later on they were able to pass a balloon and dilate it. And here is the final results after stenting. So, and that's it. And I really want to thank Dr. Shasteva, Dr. Alturk, and Dr. Kumar. They really helped give me insightful tips for this presentation. And Dr. Taylor, who told me where to look when it comes to the basic science part of things. And with that, if anyone has any questions.
Thank you, Mariem. Very good talk and review of an important topic, and obviously one that creates problems both clinically and in the cath lab, both in the clinic and in the cath lab. So that looks like Dr. Smith has a question. I saw he raised his hand out there. He's on the line, Dr. Smith.
Yeah, just a comment. One of the large groups that we see in a growing group are patients with end-stage renal disease. And they often, when calcium scores are done, often have very high calcium scores. And in fact, we were seeing patients who, because their calcium scores were so high, that we often recommended coronary angiography prior to going on the kidney transplant list. And we found that most of the patients we were doing that did not have obstructive disease. And these patients had calcification in their lungs and everywhere else that were delaying their transplant listing. So just a caveat, I think, around looking at calcium scores and deciding what to do with statin therapy, because the studies in end-stage renal disease have not shown benefit of statins in patients with mild or moderate LDL increases as far as secondary prevention. I think there have been about 4 studies. And so the statin therapy does not seem to apply to those on dialysis. And then just another thing we notice is that the patients undergoing transplant evaluation often get MRIs of the abdomen, where you can see whether there's any report of atherosclerosis, or on CT, any calcifications of the abdominal arteries. And I haven't seen data to say that if that is normal, that they're at much lower risk of coronary artery disease, but it seems that they might be. And I know Val Fuster had a study going a few years ago where he was looking at that. But just a question related to calcifications: how useful is looking at calcifications in other parts of the body, and how that might impact what we do to try to prevent coronary events?
Yeah, thank you for your question. Actually, that's a really good question. In terms of looking at extra coronary calcification, the last one of the studies that I showed did suggest that there was a correlation, and they were suggesting that we should start looking at vascular calcification as a whole and grading that, because there was an increase of all-cause mortality with an increase of calcification, not only coronary calcification, but also with extra coronary calcification. So I think there's a lot of unknowns in terms of like how to use the calcium score. I think we know that it is a good risk predictor, but then the results and what to do with them and how that would change our management in terms of risk stratifying patients, instead of lumping all of them if they have a calcium score of more than 400, regardless of if it's more than 400. And you're talking about a score of 450 or more than 1,000, and if it's in the left main or multi-vessel, or and to match that with their risk factors is still unknown. So, and whether or not, some studies were suggesting that in patients with diabetes and maybe even CKD patients that have a higher incidence of more occult or occult ischemia, that maybe we should look into doing functional testing for these patients, but we still don't know whether or not that would, help guide our management or not, and if whether or not these patients should, go further testing.
Yeah, that was sort of my question that I was going to ask, was sort of related. Another group that we'll see that has very high calcium scores frequently are patients with prior chest radiation, from often malignancy, maybe as a child or what have you. Sort of the classic is Hodgkin's lymphoma as a child, and then Hodgkin's disease as a child who get chest radiation, and then as an adult will have very high calcium scores. Obviously, I don't think there's a lot of data necessarily that I'm aware of on this particular group. There may be some smaller studies, but I guess sort of my question is coronary calcification all the same regardless? Or, if you have one of these extrinsic factors, be it, end-stage renal disease or prior radiation, is that like potentially a different process and maybe not have the same degree of risk as just your intrinsic, atherosclerotic disease?
That's a great question. And firstly, Hodgkin's lymphoma, yes, the radiation does play a factor, and they are shown that they have a higher risk of coronary artery disease in a younger age, especially if they had radiation therapy and not only chemotherapy. So it's the radiation that causes the more coronary risk, and the chemotherapy, especially with doxorubicin, increases their risk of heart failure. But in any case, to answer your second question, so the thing is, I think, it's really hard to segregate between, intimal and medial calcification. And definitely medial calcification when it comes to the coronary arteries, it's much rare than medial calcification. The majority is intimal calcification. But there is maybe, especially in the patients with CKD, that we see, as Dr. Smith mentioned, a really, really, really high calcium score, and yet no really significant stenosis, that these patients might actually have more medial calcification, and that's what we're seeing. And so medial calcification is more concentric, and it weakens the vessel and it stiffens it, but it really doesn't cause luminal narrowing, even in the severe forms, unless it's. But you can always see, and you can see this even on pathology more clearly, that there's a lot of times medial and intimal calcification can happen in the same segment, so it's really hard to know. But yeah, and the same, and the second group that have a higher incidence of medial calcification are the diabetics, but they have a very, very much higher occurrence of intimal calcification. So they have more risk of ischemia, because that form of calcification or that plaque does compress the lumen and compromise flow. And if it's unstable, it causes ACS. I hope I answered your question.
You did. Thank you. All right. Well, any other questions? I mean, I probably have time maybe for one more quick question.
Robbie, Stan Sherman, can you hear
Yes,
me?
sir.
We've all had patients who've had acute coronary syndromes and don't have any coronary calcium. I just wonder if there have been any recent studies. The old studies showed that would only happen probably about 8% of the time. I was just wondering if she ran across any other recent studies about how often we have acute coronary syndromes without calcification.
That's a really good question. So actually, in the first study that I showed by Rumberger, that was published in Circulation 1995, he showed that there was a correlation between the amount of calcium and atherosclerosis, but the amount of atherosclerosis when the calcification was there was 5 times more, which does indicate that there is a risk that you can have no calcification and you do have like non-calcified lesions. I don't know, and even in the MESA studies, they do see that there is a relative number of patients that had a calcium score of 0, but they did have, there was some CVD risk. So a calcium score of 0 is not necessarily 0. But then again, the patients are usually younger. And so it's not really, and the relevance, it's not really cost effective to go chasing after scanning these patients. And in those instances, lifestyle modification is key.
Good talk. Thank you.
Great job.
Mariam.
Thank you.
Good talk, good review. Thank you everyone for tuning in. We have our journal club next week. So we'll be presenting 2 journal articles and discussing them, and look forward to seeing everyone next Friday. Thanks again, Mariem.
Thanks. Thank you, guys. Bye-bye.
The preceding program is copyrighted by Emory University.